molecule that defect in patients with TTP to current development of the guidelines for the diagnosis and treatment. So I want to share that with you because it was just recently published, probably like in a week or two. Okay, so I got interested in TTP about 18 years ago when I was a resident at WashU, Washington University in St. Louis. During my residency, I saw this patient. Probably some of you, if you're a patient, this sounds like a pretty familiar. You know, it's a 42-year-old woman came to the hospital with kind of blurred vision and gait disturbance, and then she actually disoriented. And then, of course, in the emergency department, the platelet count was kind of low. It was 24,000, and also hemoglobin is also low. And the LDH is very high, and the creatinine is slightly elevated. So because of the neurologic symptoms, so the CT scan and found a lot of, small brain influx. So that the patient was admitted at the time. And of course, the blood smear also shows some schistocyte, which is the broken down of these red blood cells, so like a hamlet kind of cell. And of course, this patient was diagnosed as having a TTP. To be honest with you, when I was first year resident, I have no idea about TTP. So I have to actually go back and study and learning about TTP. So after spend and also study TTP. So I set up the first assay to detect this ADAMTS13 activity at a time called the van Wouwelband factor cleaving protease activity. So just using van Wouwelband factor as a substrate, and then you look for enzyme activity and that can cleave van Wouwelband factor. So and using this technology, I will be able to isolate the normal van Wouwelband factor cleaving protease, now we call ADAMTS13, from the blood donor, from the normal donor blood plasma. And eventually I identified it is called ADAMTS13. So this really paved the way how we understand the pathogenesis of this disease. And now we all know that this enzyme is essential to cleave this gigantic molecule called the van Wouwelband factor, okay? Without this enzyme, this van Wouwelband factor will stick together with platelet. It look like a spaghetti and meatball kind of together. That will jam your small vessel, so your tissue or your organ will get that damaged. So I consider this as like your saw doesn't work, so your bush getting pretty kind of messy. And normally, if you have the saw moving around your vessel, you actually have a very clean vascular system, so you will not have blood clot. Okay, so ADAMTS13 is like your saw, your chainsaw. Okay? So just last couple of weeks, we actually published this International Society of Thrombosis and Hemostasis guideline for the diagnosis and the management of TTP. Okay, to develop those guidelines, actually, it take a very long time. It take about almost a year, more than a year, actually, to starting from collecting data, or basically search all the literature, looking for evidence. And then we have a specific team. We have both teams. One is called the methodology team. Those are reviewing literature and compiled evidence. We also have a so-called TTP expert panel, and as well as patient panel. We actually included 2 patients into this expert panel to help us to develop what is most variable thing that the patient is actually looking for in this guideline. one of the, I think, panelists is actually here tonight in the audience. So I'm very proud to present this on behalf of our panel. And we have, over the years, we have two in-person meetings and actually discuss and then assess all the evidence and then vote for the recommendation for each recommendation, okay? So, and the ISTH guideline actually issue a guideline based on the evidence and also based on how strong the recommendation is going to be, okay? If the recommendation says it's a strong recommendation, that means the panel recommend this particular diagnosis or treatment issues. So if a panel say recommend, that means it's a strong recommendation, okay? Which means the panel recognize if we take this recommendation, the desirable effect will outweigh the undesirable effect, okay? And then most patients will accept this recommended course of action. And most clinicians should follow the recommended course of action. And then the recommendation can be adopted as a policy in most situations, like in an organization or health insurance, those kind of stuff. Usually based on high quality evidence, okay? However, in some cases, because it's such a rare disease, the strong recommendation and also such a potentially fatal disease, sometimes strong recommendation can be issued in the absence of a high certainty or high quality evidence, because we're lacking a lot of double-blind clinical trial, okay? And then also in TTP, so you will see a lot of recommendation is actually called a conditional, which means the guideline panel usually suggest, not recommend, okay? If you see the words suggest, that means the panelists actually believe the desirable effect probably outweigh the undesirable effect, okay? And most patients would accept the suggested course of action, okay? This kind of a guideline help patients make a decision that is consistent with their own value and preference, okay? And of course, a different choice may be also appropriate for different patients. And so then when the policy making or standard setting around the conditional recommendation should be actually undertaken with caution. So unlike the strong recommendation, and you would take that recommendation without hesitating, okay? And so, so for the conditional recommendation, of course, it requires a substantial debate and engagements with a lot of different people. For example, we need to discuss that with patients and also treating physician as well as the insurance company, because sometimes the conditional recommendation, the insurance company say, I'm not going to pay for that. So that kind of stuff. So, and so that's why you will see this, the strengths of recommendation in the different recommendation, okay? So now I'm going to just touch a little bit about several recommendations that we put forward for diagnosis and treatment. The first is about a diagnosis. We came up like 3 different recommendations, okay? And so recommendation 1 basically telling you that if you have an ADAMTS13 test capability, and if the patient has a high probability of TTP based on the clinical symptom like platelet count, schistocyte, LDH, and so on and so forth. If the suspicion is very high, and then you also have the capability to test ADAMTS13, then the panel recommended you draw ADAMTS13, but you don't wait for ADAMTS13 result, okay? But you start with plasma exchange right away. you also give corticosteroid, as well as adding caplacizumab, which is a new drug that the FDA approved it last year. So it's actually block von Willebrand factor and the platelet interaction. So you prevent the spaghetti and the meatball sticking together. Okay, so that's what this drug is about. Okay, and then when you're giving this to the patient, then you look for the result, okay, of ADAMTS13 test. If ADAMTS13 testing comes back and say ADAMTS13 activity less than 10%, you continue this course, okay? Continue plasma exchange, corticosteroid, caplacizumab, okay? If ADAMTS13 comes back and say greater than 20%, we consider this as a negative test, meaning that you don't have TTP. So in this case, we recommend to stop caplacizumab and also stop plasma exchange and corticosteroid. You look for other diagnosis. You may not have TTP, even you have thrombocytopenia and schistocyte, but you may not have a TTP. You may have a different disease, okay, which we're not going to talk about today, but that's what this recommendation is about, okay? However, if the result is kind of borderline, let's say your ADAMTS13 come back, 15%. So what do? Okay, but clinically you look like, based on all the criteria, you look like a real TTP, but the ADAMTS13 doesn't support that. So in this case, clinical judgment is required. So basically, the clinician have to talk to the patient, see the patient, assess the patient as a whole person, and then decide what will be the best treatment for this particular patient. Let's say you can give a plasma exchange and things like that for a couple of days to see if a patient responds. If it responds very well, that means it's supporting. You may still have TTP. It's just your ADAMTS may be slightly higher than what we expected, okay? And if it doesn't respond at all, then you can say, oh, no, this patient doesn't look like TTP. We need to look for other reasons. So that's what we call using your clinical judgment to guide the treatment. And of course, always consider other diagnosis when this is the situation, okay? So recommendation number 2, basically, if the clinical suspicion of TTP is not really high, the chance of having TTP based on platelet count and creatinine and other stuff, less than 90% sure. And of course, you have ADAMTS13 test. In this case, you still going to go ahead and draw ADAMTS13 for testing, and then start a plasma exchange corticosteroid right away. But in this case, you do not add caplacizumab. So you wait for ADAMTS13 result to come back. If the ADAMTS13 result come back less than 10%, and that support your diagnosis of TTP, then you continue. You're adding the caplacizumab and also adding lutekizumab. So lutekizumab is actually the drug that block the antibody production, okay? So this way, in the long run, it prevents disease relapse. Yeah. If the ADAMTS13 comes back greater than 20% as previously, and so this patient may not have TTP at all. So in this case, you will stop caplacizumab, okay? And you do not add a caplacizumab, and also stop plasma exchange and corticosteroid. You consider other diagnosis, okay? And again, if it's a borderline, if there's ADAMTS13 between 10 to 20%, clinical judgment also required to guide the further management, okay? Huh? Anybody has a question?
It's a little complicated.
It's pretty complicated, yes, yes.
A protocol, which
right.
is great.
Yeah, yeah.
You know what I mean? Like, if you see this, then this, then that's going to make it easier for people to diagnose it.
Right. That's right. Yeah. JB.
I had a question. It seems like one of the issues that I've heard about has been, depending on where you're at geographically, possibly a lack of clinical judgment because people had not seen TTP or did not know much about it. I know it's misdiagnosed sometimes. So What do you do in that event?
Todd, that's exactly the reason why we actually developed this guideline, because the way of people, the clinician, how they respond to the patient or look for TTP, evidence of TTP is totally different. Every place does different thing, okay? Right, so the clinical judgment, so I think the most important thing is education. So the more clinician knows about TTP, the more people hear about TTP, the better chance that patient will be diagnosed correctly. Okay, did that answer your question, Todd?
You're on mute.
Yes, sir.
Okay, thank you.
Thank you.
You're welcome.
Dr.
Okay.
Zheng, Dr. Zheng, one question.
Yeah. Hey,
okay, are you saying now, like when it's recommended that a client, a patient is given rituximab, they're also given this new drug along with it?
Yes, yes. If the clinical suspicion is very high, and plus you're gonna get ADAMTS13 within, let's say, 3 days,
Right.
and you will give a caplacizumab, okay, up front. If a clinical suspicion is kind of borderline, not really high, intermediate, let's say a patient coming with a platelet count of 100, creatinine is 4 or 5, okay? So we know this patient doesn't look like a TTP. It may have another disease called the hemolytic uremic syndrome. Have you heard that? Called the HUS. Okay, so differentiate TTP from HUS is hugely important, because if you treat them wrongly, and one will develop a renal failure, eventually the kidney will be gone. So you need a kidney transplant, right? So this patient has to be treated with another drug called eculizumab, which is an anti-complement drug that is inhibiting complement activation. Because these two diseases have completely different mechanism or etiology. See what I mean?
Okay.
Yeah.
Thank you.
Yeah. So now having the caplacizumab on board is actually immediately block the microvascular thrombosis. It's actually preventing your blood, your platelet sticking to the von Willebrand factor and jam your vessel. So this drug is actually have an immediate effect.
Okay, so it should be more effective than just the rituximab from in the past.
That's right. So rituximab take like 3 weeks to work. Okay. Because it's bind to your B cell, killing your B cell that produce antibody. So only after 3 weeks you will see the effect of rituximab. But the caplacizumab will have an effect right away. The earlier you give, the better.
Okay.
You see what I mean? Yeah.
Yes.
Yeah.
Well, that's an improvement. Okay.
Yes, that's a hugely improvement. If you look at the clinical trial data, on the patient who had a plasma exchange plus rituximab, corticosteroid, and caplacizumab, this patient had no mortality, 0 mortality. Okay, but for the last 20 years, we have not been able to reduce the mortality to 0. With just plasma exchange and rituximab and corticosteroid. We reduced the mortality from 90% to almost 10 to 15%.
Wow.
Okay.
Okay.
But we will not be able to reduce to 0. So this drug, at least for the clinical trial patient, I guess that they select the patient a little bit of modest disease, not a very severe disease, and nobody died. But in the control group, they do not add in caplacizumab. 3 of them died.
Wow.
Among, I would say, 47 patients. So that's a huge, huge improvement. Right?
Okay, great.
Yeah.
Okay.
All right.
Do you still need to receive the rituximab and this medication prior to any surgical procedure?
The surgical procedure depends on what kind of surgery.
Okay.
Right? What kind of surgery you're talking about? You're talking about splenectomy or remove the spleen? as a treatment of TTP, or you have emergency surgery for, let's say, somebody's leg broken, you know, need to fix that?
Let's say, well, I had a knee replacement.
Uh-huh.
Okay, so I would still need the rituximab and this new medication?
No. So if you need a knee surgery, the caplacizumab has to stop for a while.
Oh.
Because it will cause bleeding after surgery. So you cannot use caplacizumab if you are planning for knee surgery.
Okay.
But usually if you have an acute TTP, we are not gonna do the knee surgery because knee surgery is elective surgery. You can pick a best time to do that. You don't have to do it emergently, right?
No.
Yes. So we will usually stop this drug and make sure that your TTP is recovered, and then we plan for surgery.
You mentioned splenectomy. Well,
Yes.
what is that? The removal of a spleen?
Yeah, removal of spleen. Yes, in the past that has been used at least in the refractory patient. So patient doesn't respond to plasma exchange, doesn't respond to corticosteroid, and doesn't respond to rituximab. And in this case, we remove the spleen because the spleen is like a site to manufacture your antibody. Okay.
I know about that because I had my spleen removed.
Yes, yes. That has been a treatment in the past, but
yes,
we do not use this very often anymore because now we have a better drug. Okay, we have a rituximab, we have caplacizumab. We don't necessarily need to remove the spleen. So we only use it occasionally now.
Okay.
Yeah. So, so recommendation number 3 is basically saying, regardless of the pre-test probability, regardless how high the suspicion your TTP is, okay? If you do not have ADAMTS13 test capability, let's say in Brazil, for example, I was just asked the other day by a Brazilian physician. She said that they do not have ADAMTS13 test in Brazil. And she was asking me which test should I establish in Brazil so that I can help my patient. So if you do not have that test capability, you can still use plasma exchange because it's still going to save life. You can still use corticosteroid, but you do not use caplacizumab. Okay. The reason being, caplacizumab, if you're not using correctly, it can cause bleeding. Okay. So you want an expert to use that. If your center doesn't even do the test, that means you may not have the expert there to help you. Okay. So that's the rationale. And then, but you still can consider rituximab because rituximab is more kind of benign and safe drug to use. Okay. Got it? Yeah. I don't think this apply to the United States. So everyone will have access to ADAMTS13 test. Okay. So, and also I'm going to go very briefly about the treatment recommendation. Okay. As we already mentioned, corticosteroid is actually very important because corticosteroid, like prednisone, those kind of stuff, is actually help quiet down your inflammation. Okay, it's kind of eliminate your inflammation because inflammation is really bad. It causes your endothelial cell to release a lot of VEGF, so you want to add that. So recommendation 1 for treatment is adding corticosteroid to plasma exchange. It's better than just using plasma exchange. Okay, that was the recommendation number 1. It's actually a strong recommendation, but in the context of very low certainty evidence because nobody has done the comparative trial. So that's why the evidence is not really strong. But the experience told us corticosteroid works. Okay. The other thing is about the rituximab, and the rituximab should be added to every patient who had either initial episode or relapse. Okay, because rituximab help reduce the relapse in the future because it limited antibody. And this is also a conditional recommendation in the context of very low certainty evidence. Capivasertib, and for every patient in the acute setting now or relapse, every patient, the panel suggests to use capivasertib over not to use it, okay? So that's what the recommendation is about. And then what about rituximab in remission? Let's say you are now platelet count is normal, but when you go back to see your doctor and then they say your ADAMTS13 is still low, but you don't have any symptom, okay? That's still not good because it's, if you have low ADAMTS13, you may relapse sometime, okay? So the goal is to try to eliminate the antibody so now ADAMTS13 can return to normal, okay? So in this case, we still recommend you use rituximab to eliminate antibody and allow your ADAMTS13 to come back, okay? So because the result shows that the previous study show if you use rituximab, the chance of relapsing is much lower over 10 years. On the curve, on the top curve is the patient who received rituximab. You see fewer patients have relapsed. And the bottom curve is the patient who didn't get rituximab. They actually, in 10 years, half of the patients already having relapse disease. You see, so that's why the recommendation actually is about. Okay. So the next one is if you have a congenital TTP, not acquired, not due to antibody. If you don't have any symptom, let's say your platelet count is normal, you don't feel anything wrong. In this case, we actually suggest either way, either give a plasma infusion, every week or every 2 weeks, or you just wait, watch and wait. You just see what happens, okay? And so either one will be acceptable, okay? Because giving plasma also have a risk, having reaction to the plasma. And then the last one, it's not the last one, the second last one, is a TTP during pregnancy. If you are pregnant, okay, but you have TTP, or if you don't have symptoms yet, but your ADAMTS13 is already decreasing from previous level, okay? In this case, the panel still suggests or recommend you give prophylactic plasma exchange, okay? Plasma infusion or plasma exchange, okay? Over not to do any of it because it will actually prevent the mother mortality, also prevent the kids having problem as well. So actually doing both. So in conclusion, so I've been talking to you about the first the ISTH guideline, for the diagnosis management of TTP, and the panel really emphasizes the ADAMTS13 testing, and whether during the acute setting for diagnosis or measure them during the remission for follow-up, and also decide what to do at that point, okay? Even you don't have symptoms. So in the acute treatment, the plasma exchange plus corticosteroid, rituximab, and capivasertib, so the fourth drug, are really now the cornerstone for management of immune-mediated TTP, meaning acquired TTP. For congenital TTP, you don't need rituximab and capivasertib, okay? You may need plasma infusion or plasma exchange. You don't need the other, okay? So, so this combination has really accelerated the recovery. There's a study showed the ICU stay, hospital stay is actually dramatically reduced. Also, when you have these 4 drugs on board, you don't have exacerbation. And some of the patients you may remember during plasma exchange, some patients platelet count rise and then fall again, and rise and then fall again, okay? So during treatment, it is exacerbated, okay? But if you have a tacrolimus, this exacerbation will be eliminated, okay? And so therefore, you can actually get out of the hospital earlier, okay? And also having rituximab prevent long-term relapse, okay? So you can eliminate antibody. So by doing all these, so the ultimate goal, of course, is to reduce the mortality and morbidity, you know, and there's also long-term consequence of, because of, you know, tissue ischemia, particularly brain ischemia and the heart. So if you can prevent this happening in the acute setting, you actually have a long recover, you know, a very sustained effect in your disease management. Okay. So there's still a lot of ongoing research need to be done. For example, recently there's a paper that published showing that if you just use caplacizumab, corticosteroid, rituximab, you can actually cure that TTP patient also without plasma exchange. And this is particularly true for the patient who doesn't accept blood products, okay? And so that's number one. So this could be actually further investigated, okay? And the other thing is, can we use recombinant ADAMTS13, meaning the ADAMTS13 we produce in the laboratory, can we use this to treat patient instead of giving plasma exchange, which is have a goal to replenish the ADAMTS13 and remove antibody, right? If I can have the purified protein directly inject to you, that probably will also take care of the missing ADAMTS13 issues, okay? And the other thing is, in our laboratory, we have used the platelets. As you know, platelet transfusion is very common clinically when patients have thrombocytopenia, right? Let's say if we hide some ADAMTS13 inside the platelet, allow them to carry through your body and then target it to the thrombosis, that where the thrombosis is, that's just like a mini bomb coming to and look for, you know, the clot and then bomb it. So we actually showed this is highly effective in the mouse model, and since that we haven't done a clinical trial yet. So these are something that we're really interested in trying to see if we can develop as a novel therapeutic modality, okay? And also my laboratory is very interested in understanding what are the genetic and the environmental trigger that actually can contribute to the disease process. As you know, someone may have lacking ADAMTS13 for a while, but you don't have a disease until you get infection, until you get pregnant, until, you know, things like that, or a surgery. So some kind of life stress that causing the TTP, the full-blown TTP. So we want to understand how these actually contributed to the whole disease process. Okay. So I think that's all I have to say. And if you have any question, please.
Yes, I would like to know, with this COVID